the chest ultrasonography, and just we direct your mind away from echo a little bit to what we call it critical care echocardiography. And by the way, the echo is not shouldn't be only echocardiography, but echo can be echo chest, echo abdomen, echo vascular. Echo is the reflection of ultrasound. So let me start with this gentleman who was transferred to our hospital as a 20-year-old victim of RTA, transferred overnight from another hospital with history given as traumatic brain injury, and everything else was reported to be totally normal. Apart from some lung contusion on the CT, and this is the X-ray on arrival to our hospital. Do you see anything abnormal in this X-ray? Maybe some haziness here, but do you see any evidence of pneumothorax or effusion or anything? Right. This is the CT which he came with, which was totally normal. As a part of critical care round, we used to use the ultrasound at the last point in critical care round. And we examine patients with ultrasound. And this, on the round also, more evidence that this patient, he was ventilated, and the peak airway pressure was totally normal. Blood pressure was maintained very nicely. Heart rate was fine, fully sedated, calm, and nothing was abnormal. And then we did the examination with ultrasound. As I showed you before, we go back again to this one. If you see here, you can see that this is the shadow, this is the rib, and this is the shadow of the rib, and this is the shadow of the another rib, and in between this is the intercostal space. You have to see hyperechoic line here, which is the pleural line. This line doesn't move back and forth at all. It's fixed. It does not slide. So the sliding here is negative. What we do next is to fire M mode on the middle of this pleural line, and then we see what we call it barcode sign. There is no seashore sign. You don't see the lung. If you don't see the lung here, in here, it's all like a barcode. This is a definitive sign of pneumothorax. Then, when we do examination, you have to do examination of both sides. You should not stop in one side. Then this is the right side. And you can see here, if you look carefully, that there is no sliding here, this pleural line, totally silent, but when the probe moves down, there is some sliding there. This is what we call the lung point. And we do fire the M mode at this lung point. You can see the seashore sign. This is a sandy area of the lung. This is skin subcutaneous, and this is the pleural line, and this is the lung normal totally. So the right side was containing pneumothorax, and the left side was containing also pneumothorax with sure signs. When I said this is the case, the people said you are crazy, because we had normal X-ray, and we had normal mechanics on ventilator. Blood pressure is maintained very well. Why you have to think of pneumothorax while the patient has no signs of pneumothorax, X-ray is normal? He just arrived with a CT done a couple of hours back. This is what we call the curtain sign. You see, it's like a curtain. When we put the probe of the vascular probe at the angle of the lung, I mean, in the mid-axillary line, 8th or 10th intercostal space, you see the liver moving down, and the lung comes across. This is the liver, and this is the diaphragm pushing the liver down with inspiration, and the lung expand like the curtain. We call it curtain sign. It means that the pneumothorax doesn't reach this area of the lung, because this is the air likes to be up. So the most common area for the pneumothorax to accumulate is the front of the chest, not the basis. We went for CT, and this was the picture. The left side actually containing massive pneumothorax. And the right side, this is the lung point, the area which I showed you, the area of no sliding, that can meet the area of sliding. This is the point exactly where there is no pneumothorax here but there was pneumothorax above. But the message from here that the normal X-ray does not rule out presence of pneumothorax. The sensitivity of chest X-ray to detect abnormal parenchymal or pleural diseases is around 40 to 50%. So we have false negative of around 50% of cases. How much do you expect from this X-ray? This is another X-ray, which you see here. You don't see the copula of diaphragm in either side, and the angle is totally obliterated. Who agree with me that there is a massive pleural effusion on the right side? Can you show up hands? We all agree that there is massive pleural effusion on the other side. Actually, the treating team was dealing with this patient. She was in type 1 and type 2 respiratory failure, and they prepared intercostal tube. I was passing by. I said, let me just do the ultrasound first, because the ultrasound is as equal as CT, which is the gold standard in ruling in the presence of pleural effusion and many other things. So ultrasound examination done, and this is the case. This is the liver, this is the diaphragm, and this is the lung. It's hypotonized like the liver. This lady was very obese. This is the diaphragm. You have to identify where you are first. This is the liver, this is the diaphragm, and above the diaphragm is the lung. So this is very consolidated lung. When you see there are white dots inside the lung, that some of them disappear and some of them, they do not disappear. We call it dynamic versus static air bronchogram. Static means that the white dots does not disappear when the air comes into the alveoli, indicates collapse. While the area that disappear, the white dots disappear, indicates dynamic air bronchogram, which indicates that this area is still receiving air and it's consolidated. Do you see any hypoechoic shadow above the diaphragm, indicating presence of fluid? There is no single drop of fluid above the diaphragm. So we concluded that this patient has consolidation / collapse plus collapse, and there is no single drop of effusion. If you remember in your life, you might come across a case that you enter your needle to tap a patient and then you don't get any fluid back. This might be one of the cases. Look at this one. Do you expect any effusion in this patient? The angle is seen very clear. The sulcus is very nice. The diaphragm is drawn nicely, bilaterally. I personally don't expect a presence of any effusion here. Well, the case came like this when we did examination with ultrasound. Again, the liver, some hepatic veins, IVC, diaphragm, and then anything above the diaphragm is going to be the lung. But I see hypodensity above the diaphragm here, which is pleural effusion. Look at this side, the left side here. This is the right side. So there is effusion, while you did not at all expect presence of effusion. This is not the only message here. The message that the left side, which looked totally normal, is showing a lot of, this area is almost like the liver. We call it hypotenized lung. This is on the left side. So this is the spleen, diaphragm, lung above, with area which looks like a liver consolidated. Look at the dots inside, the white dots inside, that some of them disappear, some of them they do not disappear. So this lung is consolidated, collapsed, while the X-ray is not showing any sign of pneumonia or collapse or effusion. Another view, which we call it a spine sign. Because any fluid is very enhancing the transmission of ultrasound beam, like the liver, the fluid also enhance the transmission of ultrasound. Look at here, because we are putting the probe like this, the ultrasound beam find a fluid and then a consolidated lung, which is hypotenized, a good media for the ultrasound to transmit also. It goes up to the back till the spine, and then you see the shadows of the spine. It's one of the confirmatory signs of pneumonia. So this patient on the left side has more than one sign of pneumonia. If you add to this presence of white cell count, fever, signs of sepsis, you would have definitive diagnosis of pneumonia as a reason for this patient's sepsis, although the X-ray was not looking like at all abnormal. And this is the CT of this patient, showed the same which we showed with ultrasound. This is confirming what is in the literature, that the patient, the ultrasound is equal to CT in most of the lung diseases. How much you expect here? Also, you would agree with me that there is some consolidation, maybe some collapse and effusion, but you never say that one predominates over the other. And then when we do the ultrasound, this was the picture. There is no effusion at all. Again, this is the liver, this is the kidney, this is the diaphragm, and here above you're going to see the lung, and you can see that the lung is almost like a liver again with a lot of B lines. The vertical lines that come from the pleura here down to the bottom of the screen, which is the pleural line, with some white dots that do not disappear with inhalation, indicates collapse. So the finding here are only collapse and consolidation, and there is no pleural effusion. This is the left side. Again, there is no single drop of fluid. This is the spleen, this is the diaphragm, and this is the lung above. And this is pleural line, this is B line, this is the pleural line, and this is all B line. It's showing that the lung is very congested with fluid because there are a lot of B lines, confluent B lines. Look at here, B line are vertical, coming from the pleura, ending by the bottom of the screen. How much you expect fluid from this chest X-ray? On the left side, I would say this is massive pleural effusion. On the right side. And you never know if there is consolidation or collapse because the angle is obscured with the effusion. Look, when we did the examination with ultrasound, liver, diaphragm, lung, with a mouse like sinking inside a pool. This is the tip of the lung with fibrin debris inside. But look at the fluid. It's like a sand inside the pleural space. One of the great advantages of using the ultrasound over the CT, that you see the fluid life in front of your eyes. And you can say that this effusion is transit or exit just by the color of the hypoechoic reflection of the ultrasound. If you see it turbid like this, you wouldn't at all expect that this is a simple transdative effusion, but it's very turbid, containing a lot of stuff, which can be pus, can be bacteria, can be debris, can be fibrin, can be blood RBCs, can be anything. The importance doesn't stop here, but the importance says also that while I'm seeing a picture like this, indicating that this effusion need to be tapped, should I go with a big tail for the intervention cardiologist or radiologist? Or I recommend more to go with wide bore intercostal tube because this might not be obstructed like the small big tail. Thank you very much.